Thank you for the introduction and the opportunity to speak again. I'm going to be speaking on endoscopic therapies for metabolic disease. And these are my disclosures, none of which are pertinent to this talk. And one of the themes that we have talked about at this meeting so far is the multidisciplinary approach to treating the obesity epidemic. And the tools that we use will vary widely based on region of the world, availability of medications, devices, and surgery. And we have to look at the tailored approach that we bring to treating obesity and what that means in our hospital, in our country, in our region, and what is the best approach to this. And the answer ultimately is that there will need to be multiple approaches over the course of time. And endoluminal therapies may fit a niche of that. And as a reminder, in addition to the worldwide obesity epidemic, one of the reasons why bariatric surgery has become so popular is not only is it very effective, but we're doing it in a safer way. So we're avoiding big operations like the one on the left, which is an open gastric bypass with a big scar, staying in the hospital for 5 to 7 days, risk of hernia, wound infection, pain control, poor early ambulation, risk of blood clots, DVT, and PE, and so forth, to laparoscopy. So the laparoscopic evolution forever changed the way in which we do metabolic and bariatric surgery. But I want to be provocative and say that really the next minimally invasive surgical revolution is not on the end of a laparoscope or a robotic device, but on the end of a flexible endoscope. And the advantages of this, I think, are obvious to everyone, that it avoids a transabdominal operative intervention or a reoperative intervention with scar tissue and increased complexity, and potentially therefore has a lower morbidity. So for those reasons, it's very ideal that we develop platforms and ways in which we can deliver therapies by means of endoscopy. The problem is that training is limited, and very specifically for surgeons to perform endoscopy, there are limited opportunities to do this. But even on the gastroenterology side, these are skill sets and devices that aren't a part of training curriculum. And historically, there's been a limited tool set. But I want to challenge that a little bit because the innovation in flexible endoscopy is changing rapidly because we have new platforms that include flexible endoscopes, but now tools and devices that allow us to perform operations that look more like our surgical procedures with tissue division, retraction, advanced energy, that allow us to do more complex maneuvering within the GI tract or even outside of the GI tract. And these are new opportunities that haven't existed before and will forever change the way in which we do endoluminal procedures. And these devices are not yet widely commercially available, but the tools already do exist and have changed many of the types of operations that we do both within bariatric procedures but outside of it as well, including different knives. This is a TT knife, an insulated tip knife, and a hook knife, which start to look a lot like our laparoscopic instruments. Other devices like caps allow us for tissue retraction, and we now have more robust suturing devices which allow for better tissue apposition and more robust suturing, as well as clips and caps that allow us to bring larger amounts of tissues together. So we can do more endoscopically than we ever have been able to do before. And increasingly, this will be true and also applies to metabolic therapies. But let's take a couple steps backwards and realize that endoscopic interventions actually were initially described for weight occurrence or recurrence after previous bariatric surgery, and then specifically after Roux-en-Y gastric bypass, because simply that is the operation that's been performed the most in the United States for the longest period of time. So there's a larger number of patients, that denominator is larger, of patients that may need a reintervention. And of course, we know that the degree of weight gain after previous bariatric surgery varies widely. It depends on the type of operation that was done, the follow-up of that patient with a multidisciplinary team, and there's a huge variability amongst procedures too. And that number that may eventually require another intervention, surgical or endoscopic, maybe upwards to 30% of our patients. And in my previous talk, I wanted to make it clear that in the paradigm of obesity as a chronic disease, undergoing a second surgery or a revisional or a conversional endoscopic procedure simply isn't a failure, but a progression of obesity, and we need to think of it in this continuum too. And therefore, there are roles for surgery, endoscopy, medications, lifestyle management, all at different arcs in patient care, and that's critically important. The problem is we have poor definitions of indications for reoperation or endoluminal procedures. And the nomenclature is changing. Is it reoccurrence of obesity? Is it failure to ameliorate comorbidities? Is it recurrence of comorbidities? Or is it an operation or device failure? And the answer is probably all of these. But when we look at the literature, there are immense challenges to compare efficacy of certain interventions because the definitions vary. So that's a huge need within our field to better identify definitions for weight gain after previous surgical intervention. And as I said before, one of the reasons why endoluminal procedures were initially described in the bariatric space was for revision. And they still are to some degree, and I'm going to review that literature briefly for you. But just as a reminder, this is how endoluminal intervention first began for bariatric surgery. And whether it was for a dilated anastomosis after Roux-en-Y gastric bypass, gastrogastric fistula, which is a reminder for many in the room that there was an era of non-divided open Roux-en-Y gastric bypass, which had a high prevalence of gastrogastric fistula, or a dilated pouch. These are the targets that we can look at from an endoluminal standpoint. But these devices really are twofold. One, they were initially described in the mid-1980s, so they're not necessarily new. And the initial FDA indications were for gastroesophageal reflux disease, not for treatment of obesity or weight-related diseases. There was relative ease of use, reproducibility, but the efficacy and durability long-term were quite poor and therefore left the market quite quickly. They were repurposed for bariatric surgery in 2004, initially described by Chris Thompson, for revision, and then Mike Schweitzer reported both a pouch and anastomosis plication in 2004, almost 20 years ago. So again, this isn't a new concept. At Cleveland Clinic in Ohio, we were part of a prospective randomized sham-controlled trial that looked at patients who previously had a Roux-en-Y gastric bypass and had weight regain or inadequate loss and a dilated gastrojejunectomy. We did routine upper endoscopies in these patients afterwards. There was some degree of weight loss, not different than the sham group, and the durability of these piston and suction-based sutures were quite poor, and that device is no longer available. But in the evolution and innovation of these devices, we now have more durable devices that allow for bigger tissue apposition and more opportunity. So what does that data look like? We also looked at a cohort of patients that had weight recurrence after previous Roux-en-Y gastric bypass in Cleveland and did upper endoscopy on those patients. Now, the caveat to this is a numerator, and we don't know the denominator in our practice of how many patients actually have a big pouch or a big gastrojejunectomy and are doing fine. But in 200 patients who had weight recurrence after previous Roux-en-Y gastric bypass, about 70% of them had something abnormal, and the majority of those, 2/3 of them, had stomal enlargement. So that seems to be a pretty good target for intervention. We know that long-term weight loss has been linked to pouch size, and we also know that the gastrojejunectomy diameter is linked to weight recurrence after Roux-en-Y gastric bypass. And of course, revisional bariatric surgery is challenging. Though we've gotten better at it, there is a still not insignificant morbidity and mortality associated with it. So what are the outcomes from these interventions? So really probably the first description and larger series came out of Boston, looking at 25 patients that underwent transoral outlet reduction after previous Roux-en-Y gastric bypass with a mean post-Roux-en-Y gastric bypass BMI of 43, which correlated to about a 24 kilogram weight gain after previous gastric bypass. And the inclusion criteria was an anastomosis bigger than 15 millimeters. And that's a pretty standardized definition of a large gastrojejunectomy. Important takeaways from this study were that they were technically successful in all, with a reduction to an average of 6 millimeters using this device and an overall 77% reduction in the diameter of that anastomosis. And this image shows a little bit how that procedure is done endoscopically. The same group is then subsequently published on longer-term outcomes. This is 3-year data looking at 6, 12, 24, and 36 months with a maintained weight loss of about 10 kilograms up to 3 years. And then that same group has now published 5-year data with a little bit more variability in total body weight loss of about 8% up to 5 years. But a big number of 330 patients, 120 of those patients have reached a 5-year mark. So it seems like at least for a mild to moderate weight loss after previous Roux-en-Y gastric bypass with low morbidity and high success rate, this may be a reasonable intervention. Another area where endoscopic transoral revision of gastrojejunectomy seems to be an opportunity to treat patients, specifically is for dumping syndrome. This is a study that looked at more than 100 patients after Roux-en-Y gastric bypass on an average of 9 years after surgery who had good total body weight loss, 30%, but had dumping syndrome. And they use a standardized scoring system, the SIGSTAD score, looking at significant reduction with an endoluminal revision of the gastrojejunectomy with good success rates. And they also note that this can be repeated with low morbidity as well. So where do we stand in terms of endoluminal procedures as primary therapy from a metabolic treatment standpoint? We know that bariatric surgery is successful for the majority of patients, and nearly 500,000 are done around the world. But as we all know, there are many patients that are seeking treatment for obesity that simply don't want surgery. And the rates of surgical penetration for eligible patients varies around the world. And I think we talked about this yesterday, that maybe that rate is higher in Kuwait. In the US, it's about 1% of patients who are eligible by criteria to undergo surgery. But many patients simply don't want that. And in the paradigm of obesity as a chronic disease, there's a lot of opportunity for multiple interventions. And endoluminal may be one of them. As a primary procedure, standalone, there are certain patients that won't tolerate general anesthesia from comorbidities, and maybe a conscious sedation endoluminal procedure would be a good option for these patients. The vast majority simply don't want surgery. They're fearful of it. They may have known someone who's had a complication, or they may have known somebody that hasn't been successful with surgery. Dr. Sawad talked about this as well when he talked about balloons. There are bridging procedures. This can occur for patients who are high risk to risk triage them to a safer bariatric surgery in the future. And then there are other patients that come to see us who never knew or were interested in treatment for obesity, but they're ineligible for other operations like organ transplantation, orthopedic surgery, or even abdominal wall reconstruction. We talked about intragastric balloons already, so I won't talk about this in much detail, but give a little bit of a US experience. They're mostly used for class 1 and class 2 obesity. The devices are temporary and reversible. Of course, you know, they may or may not require endoscopy, but they have to be part of a multidisciplinary approach. Nearly every successful publication that shows balloons have durability was within the context of a multidisciplinary program and consistent follow-up. And there's speculation about the physiology of how balloons may work. They probably do result in delayed gastric emptying, and that's the mechanism for the transpyloric shuttle, which we talked about earlier. But more importantly, they probably accommodate by causing consistent fundic distension, even though that mechanism may reduce in time, at least in the early phases of intragastric balloon placement. Fundic distension probably has a feedback mechanism that increases satiety. And of the balloons that are widely available, you know, there are different characteristics which make them desirable. 12-month duration, double balloons, up to 3 balloons, no endoscopy required. There is variability in terms of outcomes, but at least in the pivotal US studies of the devices that are available, they show about 6 to 15% total body weight loss versus 1 to 5% in lifestyle alone. They have a low rate of severe adverse events, and weight regain after removal is quite common. So where does that leave us? Well, we're looking for something more durable and effective, largely. And endoluminal suturing and plication, two different techniques and devices, have been described. The POSE technique looks at plications in two specific areas: in the antrum to delay gastric emptying, and in the fundus to decrease fundic accommodation, two of the mechanisms we talked about before. Probably the most common procedure being used worldwide with increasing visibility is endoscopic sleeve gastroplasty. This is a sutured gastroplasty invaginating the greater curve of the stomach, creating a tubularized stomach from the incisura, sparing the fundus, usually with a couple of rows of permanent sutures to create a tubular sleeve. And we're accruing data. The quality of the data is improving. This study shows 250 patients with a BMI of 37 at 3 centers with 24-month follow-up. At 6 and 24 months, the primary endpoint was a greater than 10% total body weight loss. Per protocol, 84% of the patients met this, and 53% on an intention to treat analysis. And a theme that will resonate for every endoluminal therapy is that the authors purport that this works better with adjunctive therapies, largely medications. This is a large series of short-term outcomes of ESG from Saudi Arabia, looking at 1,000 patients that underwent ESG with an average BMI of 33, 18 months of 15% total body weight loss. And this is one of the first descriptions of revisional ESG after primary ESG, which noted feasibility and at least short-term success. And as bariatric surgeons, we often look in our own surgical literature, but this is a study from Gastrointestinal Endoscopy, which is the official journal of the American Society of Gastrointestinal Endoscopy. And it's really important for us as bariatric surgeons and surgical endoscopists to look at the literature that's being published elsewhere. And this is a methodologically flawed, admittedly methodologically flawed study, but it's a case-match control of ESG versus laparoscopic sleeve gastrectomy. 54 ESG, 83 sleeve gastrectomy, case-match retrospective. Primary outcomes were weight loss and adverse events. And they reported 6-month outcomes, which in our surgical literature is not very meaningful. Percent total body weight loss was better in laparoscopic sleeve gastrectomy, as one would expect, but adverse events were 17% in that laparoscopic sleeve gastrectomy group. Most of these were mild in each cohort, but it's really important to look at the data that's being published outside of our field too, to make sure that we understand what our colleagues are seeing, that at 6 months, they both seem to be effective, but the complication rates are higher in laparoscopic sleeve gastrectomy. And as surgeons, you might say, well, of course, but the long-term weight loss is going to be better in laparoscopic sleeve gastrectomy. It was not borne out in this study, and it's an important consideration. Probably the most effective and impactful study that has come out is the MERIT trial. This is a multi-center randomized crossover trial of 157 patients with BMI 30 to 40. ESG and lifestyle medicine or lifestyle medicine alone, and then a crossover. So at 52 weeks, total body weight loss in that ESG group was about 14%, 1% of the control. And then if you look at these curves, once they cross over from sham, they match the results of that ESG group. Low complication rates and no surgical intervention for these patients. Two things. One, the outcomes, but the quality of this study construct then prompted the FDA for what we call de novo authorization, which allowed for the Apollo revised system using Overstitch to be the first and only device indicated for endoluminal bariatric suturing procedures, both ESG and TOR for revision. And these have very significant implications for procedure adoption and then potentially even a pathway for payment, which means that this may be likely to be much more adopted as this level of data comes out. Already, we're seeing small series of revision sleeve gastrectomy after ESG, small numbers of patients, mild to moderate BMI changes, but at least showing feasibility. And in another group that has done a large number of primary ESGs looking at resuturing after nearly 500 primary procedures. Failure in this group was defined as a less than 10% total body weight loss at 6 months. Again, early metric for us from a surgical standpoint. 7% of these patients underwent revision. They showed that it was safe and technically feasible and reasonable weight loss afterwards. So we've talked about balloons, we've talked about suturing techniques with 2 different devices. What else is floating around out there? Barrier liners have had some enthusiasm and are probably making a bit of a comeback in the US in a phase 2 clinical trial. The goal of these devices is to exclude parts of the foregut and proximal small bowel with different lengths and different deployment strategies. There is data, well-constructed data on this. This is a multi-center randomized efficacy study. 30 implants versus 10 controls. 26 were successful, no procedural related adverse events in a short time to implantation. And at 3 months showed good weight loss and maybe improvement of some diabetes metrics. But in a larger randomized multi-center study with a primary endpoint of treatment of metabolic syndrome at 12 months, 2-to-1 randomization, of course, BMI loss was greater at the intervention groups, but 12 months after removal, there was no difference between the 2 groups. 40% of the patients had a device-related complication, resulting in 16% premature explantation. And the conclusion from this study, a well-constructed, multi-center randomized control study, is that this device could not be used for routine weight loss and metabolic syndrome treatment. We were part of the phase 2 clinical studies at Cleveland Clinic in Ohio. That study was shut down because the expected rate of liver abscesses from duodenal translocation of bacteria was higher than 3%. So some challenges to reinstituting this device, but you may see other devices similar to do this. Another endoluminal therapy that seems to be promising to some degree is endoscopic duodenal mucosal resurfacing. This is an ablation technique. There are different companies and devices that perform this. It's done distal to the papilla, different varying lengths. And what's really interesting about these devices, they're not looking at weight loss outcomes, but diabetes metrics and specifically fatty liver disease. And in early studies, this was a first-in-human proof of concept study, look at hemoglobin A1C reduction. They were looking at kind of techniques, and longer ablation distal to the papilla probably is more effective. In a multi-center open-label study with a larger number of patients showing good results, and this one looked at not only diabetes metrics, but also transaminases and liver function test. So indications may not be for weight loss per se, and much of the literature around this is in the area of fatty liver disease and diabetes. Another area of interest that really largely is a laparoscopic technique, but there's an endoscopic version of this well, are magnetic anastomoses, these so-called bipartition procedures, allowing for normal transit through the foregut, but also a hindgut mentality for a very proximal anastomosis from the duodenum to the ileum with 2 different transgression routes. Currently, this is a laparoscopic technique. You should keep your eye on these sorts of devices and evolving mechanisms, and eventually this probably will be an endoluminal procedure. And as a segue to Dr. Butch, who's up next, and showing this slide of his, really these endoluminal procedures will work well within the context of a multidisciplinary team and probably much more efficacious within the construct of medications too. So we have to keep that in mind, that efficacy of these devices will be improved with anti-obesity medications.
5 minutes.
But where do we stand as a group of surgeons in endoscopy? This was a recent survey of the membership of the American Society of Metabolic and Bariatric Surgeons as to who's doing endoscopy. The majority of bariatric surgeons in the United States practice endoscopy to some degree. 87% do some degree of routine endoscopy on their own patients, and about 3/4 of the membership clarify this as bariatric endoscopy. And you can see of the respondents here, many of these are relatively straightforward endoluminal procedures like dilation or bleeding, but for the more advanced procedures, including stenting or endoscopic gastric remnant access, that drops down to about 1/3. and only 5% of the ASMBS membership is actually performing ESG. Interestingly, very few have formal training in advanced endoscopy, which is a huge need for our specialty. So I like this slide because clearly, actually it's a really nice slide for some of the people in the room. This is taken from Phil Shower's talk. The first two pictures are Phil performing an open gastric bypass and then the modern laparoscopic gastric bypass, which was probably around 2005. The progression from open to laparoscopy will never be traversed again, but we're not moving from laparoscopy to endoscopy. Endoscopy is another therapeutic mechanism that will fit within the spectrum of therapies for patients, especially those who are not wanting surgery, and with a combination of increasingly efficacious medications will be a viable option. I do want to give a plug for the BSAFE program, which is an acronym for Bariatric Endoscopy Skills Acquisition Focused Exam. It's co-sponsored by the ASMBS and SAGES. It's a certification in bariatric endoscopy. There's 3 components to it. It's available to members of either society. There's a web-based video curriculum, which is then followed by a high-stakes multiple-choice online exam. If you pass that online multiple-choice exam, you can sit for a hands-on technical evaluation offered at both the ASMBS annual meeting and at SAGES. As a reminder, SAGES is in Cleveland this April, so join us in Cleveland if you can. And passage of this will result in certification. And it's been helpful for surgeons to get increased credentials at their hospital. Again, credentialing and certification is local and national, but this experience has helped some bariatric surgeons increase their endoluminal procedures. So in conclusion, endoscopic access seems ideal. Relatively short duration, often ambulatory, short stays and low complications. Specifically for revisional procedures, they may reduce morbidity versus revisional or conversional operations. Importantly, primary endoluminal procedures may fill a gap between medical therapies and surgical therapies, or may augment medical therapies and vice versa. New technologies are evolving rapidly. The caveat, of course, is that efficacy and durability remain in evaluation, but don't dismiss them because of this. Because this is a critically important skill, and surgeons need to learn endoscopic skills and take leadership roles in advancing these technologies. Thanks very much for your attention.